Good evening and welcome to this evening's Ask the Expert webinar delivered in partnership with the Australian Society of Plastic Surgeons. Shortly, we'll introduce our panel who will be discussing some of the legal and ethical issues surrounding treating family and friends. My name's Sterling Wright and my day job at Avant is to manage a relationship with the various medical colleges and societies, like ASPS. We maintain these industry relationships for a number of reasons. The overarching focus, though, is to ensure that our members receive the best support possible. Thanks for joining us tonight. I can see a number of you are logging in already. We encourage you to ask questions throughout this evening's discussion. You'll note at the bottom of your screen there's a chat function. That's where you'll be asking your questions. I might actually ask people now, if you've got an opportunity to, if you can type a question in, put something in that chat box and let me know where you're dialing in from, and I'll give you a little shout out. Just want to make sure that that chat function is working appropriately. So again, I can see a number of you are logging in, so thank you for that. I should note that the advice given to this evening is general in nature. If you have some further queries about anything you hear tonight, please feel free to contact us. Hi, Jill in Melbourne. Thank you for saying good day. And Nicholas, you're in Newcastle. I can see a number of you are now logging in, so we do appreciate you being prompt this evening. So I think I might hand over to Georgie at this point. Georgie Haysom is the moderator of this evening's conversation, and she's the Head of Research, Education and Advocacy at Avant. She's a lawyer with over 25 years experience assisting doctors in a wide range of medico-legal issues. Georgie, over to you.
Great, thank you very much, Sterling, and welcome everyone. I'm delighted to be facilitating this webinar this evening. Thank you very much for asking all the questions that you asked beforehand, because that has helped us to produce the content. So I'll just introduce our panel. So firstly, hopefully you will all know Dan Kennedy, who is the president of ASPS. Welcome, Dan. We also have Ruanne Brell, who is a senior lawyer at Avant Law. Welcome, Ruanne. And we have Jodie Atkin, who is an education consultant for ASPS and is working on the ASPS ethics strategy. So welcome, Jodie. I'd like to just start by raising a few questions for reflection. So when was the last time that you helped a family member by writing them a script or giving them a pathology form or perhaps writing them a medical certificate? Or when did you last do a procedure such as administer Botox or a filler to a family member or a friend or a staff member? When did you last do a friend a favour by perhaps bumping them up your list or getting them through the triage process at your hospital's emergency department? This year at Avant, we've been looking at issues around professionalism and boundaries between doctors' personal and professional lives. Treating family, friends and colleagues is something that everybody does, but it's an area where the boundaries can become blurred and you can actually get yourself into trouble due to a lack of objectivity. So this evening, what we're going to do is work through a few case scenarios and have a chat about those, and in this context of treating family and friends. Now, as I mentioned, thank you for all your questions beforehand. We expect a kind of robust discussion, particularly from you out there in the audience. Feel free to put comments and questions into the chat, as Sterling mentioned. And we won't necessarily identify you, but feel free to put your comments in there and we'll raise them as we go through. It is a controversial topic and we expect a robust discussion, so please don't shoot the messengers. So without further ado, let me proceed by perhaps looking at, Ruanne, you're going to have a look at what the Avant claims data says about this topic.
Yeah, thanks, Georgie. As we know, treating family and friends and staff, because of the way that it's classed, is one of the things that's considered a breach of a professional boundary. In our data, we've taken out sexual boundaries and looked at the other top three issues, which are, as you can see there, aggression or bullying towards a patient, treating family members or a close friend, and we've included staff in that, and that is included, or inappropriate friendliness or of an sort of an over-friendly manner. So out of all those three things, treating a family member or a close friend was found to be the one that was most substantiated in all of those cases, which means generally, if that issue is raised with the board, in 73% of cases, it will be found to have been proved.
Thanks, Ruanne. So that's a little bit of framing up of the issues. So we're going to start now with a poll question. And the question is, do you prescribe for family members or friends? And while you're answering that, Dan, I might just ask you to make a comment about this as an opening comment about this general topic.
Well, Georgie, this is an interesting thing in plastic surgery, and certainly when you go to plastic surgery conferences, you see considerable evidence of people treating family and friends and so forth, and even to the point where sometimes on screen you see before and afters of spouses or children or what have you. So it's a very topical thing to be discussing it in the plastic surgery context. It would be very common for people to have injected family members with toxin or filler, or done a little skin cancer removal, and then we move into some of the more controversial areas of bigger procedures, and that's something where people have stronger feelings, and yet it's something that we know still happens.
Thanks, Dan. Well, there's the results, and that's probably pretty consistent with what we've been seeing over the last few months when we've been presenting this particular topic. Is it surprising to you that 28% have said no, Dan?
I actually thought it would have been lower than that.
Yes, it's interesting. All right, so that's framed it up. Now, I think what we'll move on to look at is what is actually the professional standard, the expected professional standard. So Ruanne, you're going to start, and then Jodie's going to make some comments.
Sure, thanks, Georgie. So as Georgie mentioned at the beginning, what we're talking about here tonight is not what we say or what someone else says that you should do, but what AHPRA is saying and the guidance that they provide from a professional obligation point of view. As some of you may be aware, and hopefully lots of you are, the Code of Conduct for doctors practicing in Australia was updated in October this year. And there were some slight changes, which Jodie will touch on, but otherwise this is a consistent section that says that doctors should avoid providing medical care to anyone with whom you have a close personal relationship. And we'll talk about during tonight what that means. And that's because of the impact on your objectivity, possible discontinuity of care in terms of handover and communicating with any other clinicians, and the increase in risk to patients and doctors. It's been made explicit in this new version that you must not prescribe Schedule 8 medication or psychotropic medication or any drugs of dependence for a family member, friend, colleague or staff member. And Jodie, did you want to talk about the specific surgical section?
I think it's interesting that, as you said, the Code of Conduct was just released, or the new version, in October. And while this clause has been in the Code of Conduct for a while, it actually now says you must not perform elective surgery on or family or those with you have a close relationship. And it actually mentions such as cosmetic surgery in brackets. So I think that's pretty clear now that AHPRA or the Medical Board of Australia are suggesting you must not perform elective surgery or cosmetic surgery on those people that are close to you. We won't know, or we won't know the result of this until we start seeing some complaints and what happens with regard to tribunal hearings. But yeah, that's as clear as it is ever going to get for this particular specialty, I'd say.
Jodie, is it fair to say that that is, as part of the code, recognised by the courts? Yes. Well, any guidelines that are produced by a national board come into evidence in the courts, and Georgie and Ruanne could talk to that more.
Yeah, and Dan, that's an interesting question, because sometimes on the Medico-Legal Advisory Service, we get a question that's framed in the context of, is it illegal to X? So the question in this case would be, is it illegal to treat my family member? Is it illegal to treat my friend? And whilst it's not illegal in the sense that it is not a crime to do so, which is generally what that means, there's not a law out there, the courts will absolutely factor in professional guidance, particularly those from the national body, about what your accepted or what your expected standard of care is and what the expectation of you professionally is. So that's absolutely what this Code of Conduct does. It sets out your professional obligation and the standard of care expected to you. It's also worth mentioning here, when we're talking about the code, that the code also does include, and has always included, a section that encourages and states that all doctors should have their own GP. So it's also important to recognise that issue of self-treatment or self-prescribing, which we'll address, and recognising that that's also discouraged and certainly, and that is in fact illegal in some states and territories, to treat yourself or to prescribe for yourself. But also, again, it's part of setting out the guideline that this is about having a distinct and professional relationship with another doctor providing you care.
Thanks, Ruanne. And I think oh, sorry, Dan, you're about to say something, but I'll just ask Ruanne a question before we move to you. Ruanne, and it's not about whether or not there's harm to the patient. I think the case law shows that. Is that correct?
Yeah, that's right, Georgie. So there was a case recently, a couple of years ago, where a doctor was brought before the board for prescribing to themselves and to their partner. And in all of the situations, there were repeated instances of it. The care was considered to be in accordance with what would be expected of a doctor in that position for the conditions being treated. But the issue that the board recognised was the issue of that relationship between the two of them. And in that case, the board actually imposed a condition on the doctor that specifically stated that the doctor wasn't to treat anyone whom they were in a close personal relationship with except in an emergency. And if they found themselves in an emergency situation where they had to provide treatment, they had to notify the board within 24 hours. The doctor in that case actually appealed to the board and tried to have that condition overturned, and the tribunal found that actually no, it was very important that that condition remain in place because of the need to make it very clear that that doctor wasn't to treat anyone in that relationship, so the condition remained on their registration.
Thanks, Ruanne. Dan, did you want to make a comment?
Yes, there's a question about elective surgery, and I think this is an important one because my personal interpretation of the code before the change in October was along the lines that if you wanted to do something tiny like take a mole off or take a lipoma off, it really was hardly surgery. Whereas if you were going to do an abdominoplasty on your spouse or family member, that was a big deal. But the new code doesn't differentiate at all. And the college code, the RACS code, talks about non-invasive procedures being off limits as well. So elective surgery is anything that's not emergency surgery effectively. And there's a question there about the, who's the width of the family circle, and I'm going to leave that one to you guys.
Yeah, we'll get onto that in a moment. Sterling, if you could just flick through to the next slide. It outlines what RACS actually says about about what it's appropriate to do, as you mentioned, Dan. The RACS statement on providing care to family members goes into more detail and specifically says that you're not permitted to perform any invasive or non-invasive operative procedure.
Yeah. Is
there anything else that you would like to say, Dan, at this point about what RACS says as per on this slide?
No, I'm happy to move on, but I do think we need to address what's close or what's family circle, and I think that we've got a space to do that later on, haven't we?
Yes, absolutely. All right. So, Jodie, did you want to say something at this point?
Yeah, I think there's, with regards to family, we can talk about what's a close personal relationship. One of the issues with family especially is actually obtaining informed consent, especially if you're doing a procedure on the child. Who obtains the consent? Does your partner? Who signs the forms? Would you go into the detail of explaining the procedure, or would you just assume that your partner knows all that, or would you be taking the responsibility but they would be signing the forms? So there's quite a grey area there when you think about that.
Absolutely. We've got one other question, which was around who was on the committee that made the decisions, presumably to put these things into the Code of Conduct. And I think the Code of Conduct, as Ruanne and Jodie mentioned, has been around for a while. It was the most recent version of the Code of Conduct was subject to an extensive consultation process. The draft code was consulted on by the medical board, and then they produced their final code. So it's the board with input from the profession and from the public that decides on what's going to be there. Sorry, Jodie.
I think there was some correspondence that mentioned it was actually other practitioners who had raised reports of people operating on family members that is what prompted the code to be looked at again. So I think it's actually been within the profession that's changed this version.
Yes, that's exactly right. Ruanne, I think sometimes we find that, or I'm sure doctors will know that often doctors help their family and friends and colleagues out of a desire to help, but there's a case where a doctor got into a bit of trouble trying to do that.
Yeah, there is, Georgie, and I think in these situations, there's certainly no. It's absolutely recognised that in most situations there is. All steps are motivated by a desire to help, be it a family member, friend, or staff member. And certainly in a case decided 3 or 4 years ago, a doctor who had a specialisation in mental health found herself treating one of her children, and was also treating other family members as a result, and slid into, we often talk about it as being a bit of a slippery slope, slid into a situation initially where she was prescribing some Schedule 4 medication for her child, was failing to communicate properly with her daughter's regular practitioners, including her psychiatrist, and it actually led to some of her treatment getting sort of off track. The doctor wasn't doing proper assessments before providing these prescriptions, and wasn't sort of properly securing her script pad, which is a sort of a basic expectation in terms of the risk from a prescription point of view, and issued some pathology request forms, wrote referral letters for her child, and also then ended up in a situation also where she provided a medical certificate for Centrelink for her child, holding herself out as being the treating practitioner for her daughter. And the board looked at that, and in their decision, they really did recognise that it was out of a desire to help her child that the doctor found herself in this situation. And she was reprimanded and had to undergo a substantial period of education. Now, you might be saying that's a distinguishable situation than a one-off event of removing a mole or doing an injection of Botox. But in all of their decisions and in reviewing the code, as we were just talking about, AHPRA and the board look at the common issues that have come up in a lot of these situations. And it's also looking at what might start off as one request might actually lead to repeated requests, and actually undermining your relative, friend or staff members need to get their own practitioner because you are providing this one-off care. So whilst you might be doing a one-off injection of Botox, well, arguably that's not one-off because it is most often a course of treatment. While they're there, they might say, actually, while I'm here, would you mind writing me a script for X? And because of that close relationship, you end up doing that as a favour, but then that person doesn't actually need to see their own GP or go and get proper treatment. You haven't assessed them. It's in the context of a different relationship, and that's where that slippery slope comes into it.
So we'll see how that can happen in a case scenario, which will start shortly. But I did want to mention a couple of one of the comments from one of our participants, which is, many years ago, I removed a small SCC from my mum's forehead under local anaesthetic in the rooms. It was the most stressful operation I've ever done. I ended up shaky and in a major sweat. I would certainly support not operating on a family member. And I came across, in preparing for this presentation, some literature that was published a couple of years ago, which was a study done in Germany of surgeons. And in that, many of the surgeons who answered the survey said that they had a similar response to that they'd done it, but they would never do it again, that they changed their practice when they were operating on family and friends. They were more nervous, and they also were slower. That could be a good thing, but they certainly changed their practice. I have a thunderstorm going over my head, so you may have heard that crack of thunder. So apologies for that. All right, so what we might do is, unless anyone else, Jody or Dan, do you want to make any comments at this point before we move on to the case study?
I'd just like to say that your illustration is very good. There are boundary crossings and there are boundary violations, and we want to recognize the crossings and we want to avoid the violations. We want to recognize when we're on that slippery slope and, jump back to safety. I think it's clear from, when we look at the questions, that sewing up your kid who's just lacerated themselves is a very different situation to doing elective procedures. But toxin to a friend, this was something that I've really struggled with ever since I became aware of this particular change in legislation and the idea of boundary crossings transitioning into boundary violations and getting me into potential strife.
Okay, well, Jodie, do you want to say anything before we move to the case study at this point? No, we're all good. Okay, so we might move on and be interested to have your views on this as we go through. So this is the case of Paige, and Paige doesn't have a regular GP. She takes Nexium intermittently for heartburn, but she's otherwise well, and she likes to get a script for Nexium because it's cheaper. Now, she's about to go overseas. This case scenario, which I should say is based on a kind of combination of the sorts of cases that we do actually see at Avant. She's about to go overseas on a work trip. It's pre-COVID, and she wants to get a supply of Nexium before she goes. She doesn't have time to arrange an appointment, so she asks her friend Sarah, who's a plastic surgeon, for a script for Nexium. So they're good friends. So what do you think? Is this okay? Thoughts on that? If you could put that into the chat, I might ask Dan, what do you think about this?
Sure. Well, I guess I'd say, Georgie, that I don't know enough about Nexium to prescribe it. But if the question were that she had a migraine problem and she was heading overseas and she needed some toxin into her glabella, I wouldn't have hesitated in the past to have injected her glabella. I've got pause now, but I'm going to say that in the past, I would have thought that that was completely reasonable when somebody didn't have time to go to their regular practitioner and they're a regular toxin user for their migraines to inject their forehead. But I've got a different perspective on it since talking with you.
Jodie, what are your thoughts?
I think that sometimes what seems to be a small request and seems to be okay actually leads you down that slippery slope that Roanne was talking about before. So I think you need to be careful about the requests that come in after that. And where you draw the line. Yeah,
that's right. So some of the people some of our audience have mentioned, well, if it's Botox, then that's fine too. Thoughts on that?
I think that what might seem to be a fairly low risk thing, like injecting, because you can't see an adverse event happening from that and no one will find out. I think you need to be careful given the change in the code of conduct and the fact that you could be reported for doing small procedures or even injecting. And I guess while you think your relationship might be good with the family member or your friend, sometimes if a relationship sours, then it might be a point that they decide to take up and report you on that. So the bit of convenience or the saving money might actually be quite an inconvenient issue later on if your registration's suspended or there's any conditions on it. I think also that we talk about, the fact that you might have a good relationship with someone and you can't imagine that they would possibly report on you. But sometimes when relationships break down, unimaginable things happen when people get quite frustrated. And also you don't have control of all the variables. It might not be the person that you injected or performed surgery on that makes a report. It could be someone else in theatre that thinks it's inappropriate. It could be someone that's a pharmacist that's seen the script of the same name. There could be other people that are involved and you may not have control of those variables.
Yes, that's exactly right. And someone has said that you don't need to be led down the slippery slope. You need to know when to say no. So Dan, I'm going to ask you off the back of that question. What if the person, say Paige and Sarah is a different situation. What if the person who you're treating is your spouse?
Yeah, well, it's incredibly important. I've learnt that I need to have an independent opinion on my health, and I need to have a general practitioner. And so I've certainly taken on board that I've got to consult and find the most appropriate advice for myself and treat myself appropriately, rather than just write my own scripts and do my own investigations. Yeah.
And as mentioned in the code of conduct that we saw initially, the main issue here is around lack of objectivity. And someone's asked this question beforehand, which is, what right does a patient have to choose their surgeon? What if a woman chooses her husband to perform a procedure, or her husband chooses their wife to perform a procedure? You know, Jodie, I might ask you that question.
I don't think it's a matter of choosing as much. I think it's fairly clear that now in the code of conduct that you shouldn't be doing procedures on family members regardless of who does the choosing. And I think, yeah, it's same, still stands. We've actually got some interesting questions in the chat about staff members. And does that change things? Or maybe employing staff that used to be patients, and their expectation is that they would have other procedures done, and you know what you do about that. They're not family, but it could be perceived that you have a close personal relationship with your staff members.
Yeah, so we'll talk about staff members a little bit later too. Dan, did you have a comment?
Sure. I think that there are different types of closeness, aren't there? There's family closeness, there's emotional closeness with your friends, but there's also control. And so that's where your parental control comes in. That's where your employment control comes in, and your social control. So it does make it very difficult for us to choose, you know, the appropriate path. And I think guidance in this circumstance is incredibly important. One of the things that you've said to me, Jodie, is, or maybe it was you that said it, Georgie, was that if you start to think about it possibly being a problem, then it probably is.
Yeah, I'm a big believer in the gut feeling, actually. So if you do start to think about it, then it probably is a problem. Ruanne, that brings us to this question: how close is close? What does RACS say about that in their position?
Yeah, look, RAC's position is useful in that it defines a close relationship as one of such a nature that it could reasonably be expected to affect your professional and objective judgment. So obviously, because of the nuances in this area, it's not about looking at how long you've known a friend or what their relationship is to you, a cousin versus a second cousin versus a sister versus a brother. It's actually about thinking about those concepts that Dan just mentioned in terms of emotional closeness, control, etc. And also in that context of you're in a professional relationship with someone, but can you do that objectively? And actually applying that sort of test and analysis to the nature of the relationship. So as the comment before mentioned, you know, how uncomfortable they felt treating their mother and operating on their mother, in some other relationship circumstances or staff member relationships that you just know that you can't be objective. If something went wrong during a procedure on your spouse, can you really treat that person like you would any other patient? And I think it's really about looking at it in that context. You have another relationship with this person, be it friend, colleague, staff member, employer, employee, and you also then become their doctor and are treating them, and can you do that objectively?
Right, and I think one of the things that's come up there over the past few years has been the fact that filler, which, I mean, I've injected so many friends and family members with filler and thought nothing of it, but filler does have that potential for intravascular complication, and that can cause skin loss, stroke, blindness, and so forth. And while it might be an incredibly rare thing, it's the sort of thing that you're talking about, where could you live with that type of complication? It becomes a really significant thing to consider. I think that the thing that the RACS says in their code also is that there are two components to closeness with family members. There's the fact that they are family, and then that there's a close relationship. So we were talking before about the fact that if you have a cousin that you never see, then it's not the same as the cousin that you see frequently. And I think that that's a very important issue, to look at both factors there. Yes, you're related, and yes, you're close. So there's a problem in distancing yourself professionally from that person.
Yeah, that's right. There's some great questions and comments that have come through the chat, but we might deal with them. I've seen them, or we might deal with them as we go through, so we can get to the next stage of the case study. And also we're going to do another poll question now before we move to that. I think we've covered some of these things, but is it ever okay to operate on family and friends? And then you can see the answers there. So we've spoken about RACS saying that you shouldn't treat those close to you. I guess the question is it ever okay? And we've put some suggestions in there. One of them is in an emergency. I guess we need to then look at what is an emergency, Ruanne?
Yeah, and look, again, the RACS definition is useful here in defining an emergency as treatment of illnesses or injuries that require immediate surgical attention. So maybe one of the ways of thinking about it, and this goes to one of the questions that just asked, is there an alternative? And is the patient going to be adversely affected if you explore that alternative? So if you send someone to the local hospital versus doing it yourself, is that patient actually going to be, worse off? Obviously, if there is a detriment to any sort of delay, then that's a difference. If you see something on one of your friends and you're concerned, or a family member and you're concerned about that, rather than stepping right in, maybe what you do is say, actually, I know 2 or 3 people that I would go and see myself, and you can absolutely share that knowledge with them, but just don't step in and treat them yourself.
And one of the things that I would bring up there is, I mean, I've operated on 3 of my children, but one of them I could very well justify in that she took a piece of composite skin and muscle off her frontalis, off her forehead, running through glass, and she took off a piece that was about 3 centimeters wide. And by putting it back on within 20 minutes of the injury, we had a 100% survival of the composite graft. And that could never have happened had I had to arrange for, somebody else to do it. I shouldn't say could never have happened. It would be very, very unlikely that I could have got somebody else to do it in the same time frame and achieved that result, when today, she has full skin cover and full frontalis function. So I think there are definitely emergencies where it's completely appropriate to use your skills.
And in that case, one of the ways that you can help sort of, suppose, address the situation is writing to her GP and saying, on this day at home, this happened, as I was there, I did this, X, Y, and Z, and maybe, if need be, then any follow-up would be arranged through someone else. So it's absolutely recognising, yes, there will be situations where that family member can, there's no alternative or there's not a viable alternative, but then just handling it appropriately and making sure follow-up's done appropriately as well.
And that's really good record keeping. So if something happens and you come up against a tribunal, you've actually got the notes to say exactly what happened on that day and why, is far better than trying to explain yourself out of it, 6 months down the track.
Yeah. The question about the family member with the rapidly growing SCC, I mean, it does depend to some extent on geography. If you're in a remote and rural area and you're the only person with the skills to do the biopsy, then that becomes an emergency. But if you're in a city practice where you've got colleagues who can step in and look after your brother, parent, whatever, and do that in a timely fashion, then you have access to an alternate.
Absolutely. So we've got the results up there. So 72% said it's okay in an emergency. Around about 20% fine with informed consent, never okay, and yes when they're a doctor.
That's an interesting one, yes when they're a doctor, because doctors do have some special difficulties in some situations getting care from somebody that they're not close friends with, and yet we've got a comment in the side chat here about somebody who was talking about having a lesion removed by his brother, and I've certainly taken lesions off my brother and felt completely comfortable doing so, but not anymore, given that these changes of legislation have occurred.
Okay, thanks, Dan. So we might move on to our scenario. So remember Paige and Sarah. So Paige went overseas with her Nexium, which she got from Sarah prescribing it. Paige returns from her trip, and while she's away, she noticed a change in a mole, and she goes directly to Sarah and asks for her to remove it in her rooms as a favour. Sarah agrees to have a look, but then she decides that Paige needs surgery in theatre. So we've kind of covered this similar scenario in our discussion, but Dan, I'll ask you to comment on this. Again, this is a small procedure. It's just a one-off. Why wouldn't you do it? Plenty of people would do it, right?
Well, there's an interesting case that was reported last year of a surgeon who was suspended for a period of 3 months for treating this very scenario on his sister. And so we have to be conscious of what the current climate is. And the current climate is that if you're reported for doing such a thing. Doesn't matter that you followed good guidelines and did the procedure well and didn't get a complication, you've still had a boundary crossing. And yet I think that there are very, very important issues here. I was away last year and saw what I thought was a melanoma on the leg of a close friend. Now, I wasn't able to provide treatment. I wasn't even able to provide a proper consultation because we were in another country. But I did say to her, you have to go to a dermatologist or a plastic surgeon about that. And she said, oh no, I've already been to the dermatologist. They said it was okay. I said, well, go back and suggest that a plastic surgeon that you saw suggested that that was a melanoma. And so she did. And of course it was a melanoma. And I felt that that was an incredibly important thing to push with her. And yet that's not becoming her treating physician. So you can use your knowledge without necessarily crossing the boundaries if you see something that really does need treatment.
Yeah, I think that's right. And to the comment that was made by one of our attendees before, it's an issue of where you cross the line or where you draw the line so that you don't cross it. So we've had the Nexium script, let's say it's the Botox, to make it relevant to the audience. So we've had the Botox, we've now removed a mole. What if Paige Jody comes to see you and says, well, actually now I want you to do my boobs? It's getting more complicated now.
It is getting more complicated. And I think here it's a matter of that objectivity and making sure you're taking a really good medical history. And there could be particular questions that you may not want to ask your friend because you don't particularly want to know the answers if you've got a particular personal relationship with them. You also need to be aware that there could be questions that you need to ask that they may not be fully honest about. So it's not just what you might be comfortable with. So it comes down to the objectivity and also the different questions that you may not particularly ask because you sort of do things a bit quicker, or you might not put everything down in your notes. There could be things that you've discussed while you're at the tennis game that you didn't actually discuss in a consultation and therefore didn't write it down. There's a lot of different issues around that.
Yeah.
Dan, we're not doing well with the mute tonight. Dan, any comments on that?
I think that there's an important thing in my personal situation here. I don't think I've necessarily always done the right thing by my spouse by agreeing to the repeat scripts and the investigative requests and so forth, rather than sort of insisting that she go along to the GP, which would have been a better course of action for her in many instances. But spouses and family can get pretty pushy.
Mm. And actually, there's a point with the repeated scripts that actually the guidelines mention that when you're actually doing a script for someone, you need to make sure that it's actually clinically indicated and you've gone through all the usual processes. And when you're just doing a repeat script, often you don't do that. You're just actually, writing the script out without doing the pre-work. So there could be an issue there too.
Jody, I was in the position of mentoring a colleague who had a problem with boundary violations and suspensions. And a lot of the issues surrounded not keeping adequate records of this personal interaction, not being objective in this circumstance. And of course, one of the key clinches was that the relationship went sour. And had it not gone sour, there would have been no problems.
Absolutely. Ruan, I was going to ask you, what's the legal parameters around your responsibility if you do write a script or administer a medication? So writing a script for Nexium or anything, an S4 or whatever, and administering Botox, what's your obligation?
Yeah, sure. So as the prescriber or the administrator of any medication, you individually are responsible for that. So whether or not they've been prescribed something for 10 years by their usual treating doctor, once you enter that relationship as a prescriber, you're responsible for making sure, as Jody said, that it's clinically indicated for the patient. So that requires knowing their history, knowing whether or not there are any contraindications, considering whether is that still the right medication for them. Has anything changed since they were last prescribed it, which might be 12 months. And as we know, clinical guidelines and indications do change. The same goes as the administrator. If a friend or a staff member asks you to administer an injectable, you do need to properly document that, assess them, and consider whether or not that's appropriate administration. And the problem is that doing that again in administering something like Botox is you do need to know their medical history. You do need to ask them the questions, and we'll look at this in the context of a family member. It's not always, as you may not be asking the questions, but also you might be asking the questions, but you may not be getting the full information back and the truth back. So each time you intervene or provide treatment, a prescription, or administer any medication, you individually are responsible for that and making sure that it's clinically indicated and properly documenting that. And I think it's important, and we can touch on this again for when we talk about treating staff. But one of the other things that might come up here is your staff members are not part of your advertising. It's really important to protect that employer-employee relationship and keep it as that, because as soon as you start offering treatment or free treatment, there's other aspects of your professional obligations that may get muddied into the waters.
Yep. Okay, on that note, we might move on to the next scenario, which does involve a staff member. So this is the nurse who approaches you asking for a pathology form for an MSU because she thinks that she might have a UTI. And she also asks for a script, say, because what she's had in the past has always worked. So Jody, give us your spiel on what's the problem with treating staff or, colleagues. Let's assume it could either be a nurse that you're working with in the hospital or it could be one of your staff members.
Yeah, I think there's a number of issues in terms of treating colleagues or staff members. As we said, firstly, it depends on what it's about. Yes, it might be very easy to organise this pathology form, but if it's not in your usual practice, then you're probably not asking all the questions that go along with that. You're already biased by what the sort of self-diagnosis the staff member has come to you with, which is one thing. There may be particular questions that you would feel uncomfortable asking that particular staff member, or they might be responding to the continuity of care. What happens if the result does come back that's different to what you expected? How are you going to then manage that? In doing that, it's the slippery slope. They might have other requests that they ask of you, which sort of negates their need to go back to their GP for other little things, or that they think are little. There could be issues in terms of issuing medical certificates based on whatever happens. So, and record keeping. You end up promoting sort of corridor conversations about these things, possibly, rather than actually sitting down and having a proper consultation with them like you would a patient.
Absolutely. And I think, Dan, are there some questions that you might, are there some questions that you might want to ask your the nurse who comes and asks you for this question?
Sure. I mean, you might need to be asking about sexual history. You might be needing to ask about sexual partners and their diagnoses. You might be wanting to know about past history that she or he may not want to disclose. There are significant difficulties there. I think one of the things that we've got to emphasize, just looking at the side column and all the questions, is that these are not things that ASPS or Avant have brought in. These are things that APRA has brought in, and you just want to make sure that you're all safe in your practices. Certainly, I can say that I've breached a phenomenal number of boundary crossings by today's standards in the past, and I think that we all have. So we've got to really have a bit of a change of mindset as of October 2020 with respect to operating in particular, but also investigating and so forth.
Absolutely. And it is interesting how views change about these things, and things that were traditionally quite well accepted do change with different expectations, particularly of the public, I think, and the board. And remember that the board is made up of practitioners as well as the public. And as Jody mentioned before, when we look to see some of the history around when this change occurred, the board specifically mentioned that it was other practitioners who were making complaints about doctors treating family and friends. So that's what we have to remember.
APRA typically are reactive rather than proactive, and it is typically a complaint by a member of the public or another practitioner. There's a question there on the side column about providing links and references, and there are some really excellent references that cover this. There's a College of Surgeons code, there's the Medical Board code, there's Avant documents, and I think that it's fair to say we could email those all to the those links to all of the participants, couldn't we, Georgie?
Yeah, absolutely. Yeah, we can do that.
The one we're specifically talking about, if you Google good medical practice APRA, you'll find the code of conduct on their site, and it's the one that has just been released in October, but we can provide the link. There's also, someone's raised the point that a staff member you might not treat, and they go off and are treated by another surgeon and have a horrible result, and you lose your friendship because of that. That's true, that could happen. The adverse outcome could happen on your watch also, and you could lose your friendship. So I think it's sort of half a dozen of one and six of the other, possibly, on that one.
Yeah, absolutely. And Ruanne, I was going to ask you one of the other questions that's in the chat, which is what about writing a referral for your staff or your spouse? What's the legal position writing referrals?
Yeah, so look, writing referrals, again, there's the issue of follow-up and providing treatment and discontinuity of care. So if you, again, look, if you looked at the complete situation, so the starting position is, if you don't have to do it, don't do it. That would be the starting position, because that is entering a treating relationship. There might be complications in terms of, if you're the person writing the referral, you're going to receive the results or the reporting letters, and it's not necessarily going to go to their usual treating practitioner. If for whatever reason an unusual situation arises and it is in that patient's, in the person's best interest as a patient for you to effect that referral in the first instance, loop their usual practitioners in, explain to the GP, their other treating specialists, I've put X in contact with Dr. Y, who they've previously seen if it's an ongoing relationship, or who I know they need to see for X. Can you make sure you touch base, etc., so that everyone is looped into the treatment, and that you then step out of it. So any results, if it's a request form, go to their usual practitioner. And really, particularly, I suppose, in this day and age of telehealth, it should be less impossible for you to actually effect some sort of timely contact with a usual practitioner to arrange a referral or request form. So the starting position is don't do it. If an unusual situation arises, think about whether or not there's an alternative. And if you do need to do it, then please do communicate with all their other treating practitioners.
Yeah, that's a really good point. And just looping back to the scenario, one of the issues, or one of the difficulties of treating staff and colleagues, is that often they can tell you what they think the problem is, and that in a way primes you. And whilst you may say that wouldn't happen to you, I think it's a natural psychological reaction. So if we think about the nurse there, and she says you might have a UTI, she might have a UTI, yes, it might be a UTI, but are you going to write the script for her next if it is a UTI? And if it's not a UTI, you have the obligation to follow up. Do you then refer her? And that's where the slippery slope can come in treating staff. Jodie, would you have any comments on that?
Oh, especially with that particular case where it could be, you're not doing a proper differential to find out what else it could be, and there are particular questions that you probably don't want to go down that track. So it seems easier just to go along with it and organise the form, but you need to think ahead of the possible scenarios that could happen, and mainly, as Ruanne said, that continuity of care. When you think it's something that's quite simple, can get complex very quickly.
Absolutely. So we might move on to the next scenario. Sterling, we'll jump over the next one. We've talked about that, which is the problems. We've mentioned them, and then we should have some time to raise some of the questions that we haven't quite got to. So the next scenario is about Mark, who's a registrar working in emergency, and he organises an IV for James, who is a friend who's also a registrar at the hospital, after a big night out. No records made of the visit. James feels a bit better, starts his shift, but later he gets into trouble for falling asleep at the nurse's station, so he goes home, and he later phones Mark and asks for a medical certificate. Dan, is this a common thing to happen?
I certainly think when I was a resident a long time ago, this was a pretty common thing to happen. Yeah.
Yeah. And have you got some thoughts on whether this should happen?
Well, I think there's a real problem there, isn't there? Because the fellow who's hungover may still have a high blood alcohol level. He maybe should be at home, not treating patients, and his treatment at the hands of a friend might be at risk of missing some differential diagnosis. It may not be just that he's hungover, and so there are considerable issues treating outside the formal context.
Yeah, not to mention whether it's the proper use of the hospital's resources. Jodie, I was going to ask you, what are some of your thoughts on this scenario?
I can be concerned about who else is witnessing it, whether a nurse might make a complaint about it. As I said, you don't have control of all the variables. Also with WhatsApp chats and things like that, the registrar might jump on the group and go, oh, thanks, Dan, for giving me that IV at the last minute. And, you know, that it just needs someone that might be disgruntled for some reason, or just clearly think it's inappropriate, and make a report about it, either to the hospital, which could affect some employment issues, or to the board or APRA. Also, no notes. You know, there's a whole host of things that we've discussed before, but just being aware of who might actually think that it's inappropriate and make a complaint about you. That's the one thing you don't have control of.
And once you hear about it, it's got to go to HR, and it becomes a real problem for that practitioner.
Yeah, absolutely. And Ruanne, I think you've got just quickly a case scenario to mention here.
Yeah, absolutely. So there was an interesting case that came up a couple of years ago for an intern who, in his first month of being an intern, prescribed or gave some antibiotics to his girlfriend at the time for a recurrent UTI. So this sort of brings in both those situations. She had actually attended the emergency department of the hospital where he worked, and had been assessed by the emergency doctor and discharged, and decided that, and the ED doctor decided that she didn't need a blood test. But the intern, in fact, of his own volition, decided to take that test, actually submitted the request and the test under a different doctor's name, and then actually incorrectly interpreted the results. And then led his girlfriend down on a course of treatment. Slightly later on, he actually had a separate girlfriend who he also wrote some scripts for her, effectively avoiding the need without creating any record, without doing a proper assessment. And again, there are other serious complications. Again, he was led by, that personal relationship rather than actually doing a proper clinical assessment. He was in fact suspended and deregistered, and has not actually been successful in reapplying for his registration. Again, due to the lack of insight in recognising that there was a boundary that had been crossed there. Now, you might think that's an extreme situation and be able to distinguish that from any situation you might put yourself in. But one of the things, and the way that we sort of like to characterise APRA's guidance, is it's actually a respect for the importance of the medical profession and the knowledge and the value that it brings the community, rather than undermining or considering that you're not professional. And so it's actually, in some ways, some people sort of use the guideline as the thing to tell their friend or their relative when they're asked for treatment, or a member of staff who might just, in a practice, might just book themselves an appointment, or in theatre ask if you could treat them, and actually having the guidelines to say, look, I'd really like to help you, but and you can blame the law and the guidelines and say, but unfortunately the board says I can't treat you because of our friendship, because I employ you, but I do know these three doctors who I would certainly go and see if it was me. And so you can still help them within the bounds of your professional obligations, but you're not blurring that boundary.
And I was going to ask you, Dan, a question that's come up in the chat, which we were going to deal with anyway. Yes, it's true to say that most of the audience who are here today are not registrars or interns. So we would hope that you wouldn't get caught up doing this. But Dan, many of you will be supervising registrars and interns. So if this was your registrar or intern, what would you be saying to them?
Well, I think it's a very important question because first of all, we have asked the registrars along to this evening, but secondly, registrars are in a vulnerable position in their training in that if a negative report like this goes into their employer, the HR department or their surgical supervisor, it can impact very significantly on their ability to proceed. And incidents like this do occur and we do see them at a board level and it has negative impacts. There's a few questions in the side column and I'd just like to go through a couple of them if that's all right.
For sure.
It's legal to do self-refer in Australia from Medicare's point of view, but the guidance would be that if you do self-refer because you've forgotten a referral or something like that, that you do copy in the GP as been said here. And then when it comes to a member of your theatre team, this becomes more complex. There's a couple of questions there that, that illustrate this. One is from a practitioner in a small town where all the surgeons work with all of the nurses in theatre, and that actually comes under a rather separate category of remote and rural practice. So I think that we can say that there is special provision for those in remote areas, and certainly we know about the general practitioner situation, but that general practitioner situation of the remote and rural community would also cover to the illustration that's been given here by a practitioner in a remote area where all of the theatre nurses know all of the available surgeons. And it's 1,500 kilometres to go to another centre. So I think that that has to be documented and considered and discussed so that there is appropriate acknowledgement of the boundaries and appropriate acknowledgement of the situation.
Yeah, I think that's absolutely right, Dan. But Jodie, can you cover off the issue about rural, remote and small communities?
Yeah, I think the main issue is careful case management in that respect. So you'd actually make sure you saw that person as a patient in your rooms, do a proper consultation, proper, records, etc. Not just having some consultations sort of at other social gatherings and that sort of thing. So it's really being very, very careful to treat them as a patient as you usually would. And if the relationship is particularly close, that you are concerned, about objectivity, then it would be important to try and organise for them to go and see someone else. But it's all about careful case management if you're in that particular rural situation. I noticed the other another question about someone from your theatre team. Is it okay to perform surgery on them? Once again, I think it comes back to the closeness of your relationship. So if you feel that there's going to be a lack of objectivity there, that you can't ask the usual questions you would, that they wouldn't be honest with the answers that you'd ask, that there would be some sort of impact on your relationship if there were an adverse outcome or a complication, then the suggestion is that you wouldn't do that. By the way, this is the code of conduct, and you're expected to abide by the code of conduct. It only comes into question if there's a report on you and then the tribunal assess it. But you'd need to make sure that you had some justification about the level of personal relationship with that particular person. And the theatre team staff, you might work with them, but it might not be an issue in terms of a close personal relationship with that person, depending on how often you work with them, etc. But once again, similar to the rural practitioner, you would be objective, see them as a patient, proper consultation, proper documentation of all the questions you ask with regards to history, record keeping. If they try and get you in the corridor and ask you a quick question, say make an appointment, we'll sit down, talk about it.
Dan, did you want to make a comment on what Jodie said just now? And then I wanted to ask everybody a question.
Yeah, I think we do need to address some of the more minor issues like toxin in a little bit more detail, because I think that we've had a lot of questions about that. I think that there's a really important issue here with respect to staff. One is, are they your employees or are they just people whom you work with? And I think that there's quite a difference there, because there's a power imbalance if you're paying their wages. And so that does make things different. I think if they're part of the theatre team and you're not particularly close, it creates a different scenario. And as long as you acknowledge and document and so forth, we're in a different situation. The issue surrounding staff in theatre is that they frequently buttonhole you and ask you to look at the lesion right then and there. And it's in a position where you may not have magnification, you may not have lighting, you may not have your dermoscope, you may not have records to document. And so you really have to insist on the appropriate forum and the appropriate documentation and so forth. I think that when it comes to staff, people you employ, one of the protective things that you can use is to have the policy written in your staff policy and procedures manual. So when somebody comes on board, they know what the policy is. I mean, I've operated on many staff members over the years, but I won't be doing it anymore because I see the inherent risks in it. And I think it's important that you start from the get-go by setting that expectation and having it in your practice manual. There are definitely difficult, tricky situations. There are some in our audience here who are probably the only one person in Australia qualified to do a particular unusual procedure. And I'm going to throw that to you, Georgie. I happen to know that we've got, somebody in the audience here who would be the only person I'd go to for one particular, rather complex neurological procedure. So what do we say there?
Yeah, that's a really difficult question. And if
he's
you're
my mate.
Yeah. He's your mate. Oh, that compounds it all, doesn't it? But it is a really difficult question, and I don't know. I'm gonna throw now to Jodie and to Ruanne to answer that question or to reflect on that question. What do you think, Jodie?
I stop being friends with the people that you want to perform surgery on you. Maybe no. I think it is a really grey area. If you're good mates and you know each other really well, you spend a lot of time together, etc., that would be classed as a close personal relationship. I think the only way around that, yes, there might be some justification that they're super subspecialist and they are one of the few people that could do that particular procedure, then, and this is not, particularly advice, I would make sure that every consultation was done to the absolute letter, like they would with a normal patient. All the records of exactly the questions they asked, the responses, etc., so they could justify that they treated you objectively. But then there's still the pressure on your mate to perform that particular surgery. If something goes pear-shaped in theatre, do they want to have that potential adverse outcome, something that they have to live with if you're particularly special to them? So you're putting them in a difficult circumstance from that perspective.
And Dan, so I think that comes back to the issue that we were talking about before in terms of what are the alternatives. If in fact there is really no alternative of any other practitioner in Australia that could perform that procedure on you, and you do have that separate relationship, it's about addressing that up front. It's about communicating that. It's about disclosing that and actually making sure that that's really clear in your records. So, and even if nothing goes wrong, the issue is, as someone commented earlier, would your friend actually feel comfortable doing that procedure, or would they feel that they couldn't do it objectively? They could then turn their minds to, well, you may not know anyone, but do I know anyone that could do that procedure on Dan? Actually, I don't. So I really do feel like I've got no alternative here. And then absolutely, as Jodie says, it comes down to documentation. It would also come down to actually disclosing that relationship in your reporting letter back to your treating GP, for example, by your friend. So it's really clear that what's happened is unavoidable, that there isn't a viable treatment alternative, and that you're upfront and that you've considered the issues. So sometimes, as we talked about at the beginning, part of the process is looking at the guidelines and turning your mind to it, so that when you actually just start thinking about it, or if one of my friends or colleagues was telling me this situation, what would I think, and thinking about it, and can I be objective, and asking yourself those questions. If you are determined that, yes, you can answer those questions and maintain objectivity, then document that you've turned your mind to those things. So if an issue does arise when the GP finds out that, that the patient and doctor are related, or the chemist might pick up the same surname on the script and the medication, then you've actually, you can demonstrate that you've addressed those issues. And that insight and that awareness will go a long way if an issue is brought before the board.
Yeah. So I've had occasion chairing a medical advisory committee to refuse the surgeon who wanted to operate on his grandsons. And his situation was, he said, well, my daughter is saying you're depriving my grandsons of having the best surgeon available to do the job. And I thought that was a very interesting comment. Thankfully, he came to see it differently after a little time. But, we've got to turn our minds to what that says about your opinion of your own surgery, and yet still take into consideration that there are people who are subspecialists who might be the only practitioners in a city or in the country who do a particular procedure. Can we flip right over to the other end of the spectrum and talk about toxin injections, which are almost, the cordial of the situation, and staff, because there are lots of questions about toxin injections for staff. And of course, it's something that I've done many times. It's something that most practices would consider to be a bit of a perk of working in a plastic surgical practice. And I think, it's an important one to address for attendees.
Absolutely. And Dan, well, as part of that, one of the questions that we got before this session this evening was, some of my staff have had the treatments I offer in my clinic, and that enables them to tell patients what the treatment and the recovery is like. So do you have some reflections on that? I don't know who wants to comment on that one. Ruanne, looks like you do.
From a legal point of view, my concern there is that your staff are not unbiased in recommending or talking to other patients about the procedure. And objective literature is much better as a resource to give other patients. The issue with staff is, again, in treating them, you do need to gather a medical history from them, what they might be uncomfortable to disclose things to you, which then means you don't get the full picture. It blurs the lines. There's a control and a power imbalance between staff and the practitioner. And the starting position is, you should absolutely avoid treating your staff. Even if you think that you can draw the line as they walk into your treatment room between them being an employee and not, it's fundamentally not going to be possible. What if there is a complication and they can't then present to work? What if there isn't a complication, but they say there is, and they're saying that they can't present to work? So there's really thinking through the consequences. So the starting position is, there is no need for you to be the person that provides that treatment to staff. If you want them to, or if they wish to go and have some injectables, then you can probably suggest that, if you're in a metropolitan area, they can source that elsewhere. They will certainly have some information and have access to information through your practice, but it does blur the lines, and it would be considered someone that you have a separate relationship with other than the doctor-patient relationship with, and that could certainly lead to problems.
Dan, I wanted to talk to you off the back of your comment before. Is it really that innocuous? Is it really like Nexium for a GP doing Botox and fillers?
Well, toxin, I think, is about the most serious thing that's going to happen, is a little ptosis that once in a while, so a little bit of a droop of the eyelid. But there are all sorts of social and medical issues surrounding, as you said, the history or contraindications and so forth that can be problematic. The question is, is this a special category? Because AHPRA's come out and specifically said, no elective procedures, no elective surgery, no cosmetic surgery, and the colleges says no invasive or non-invasive treatments. So we've got to look at, do we have to change our practice, or is this a special circumstance? And I'm not convinced it's a special circumstance, even though we've all been doing it forever.
Jodie, do you have some comments on that from an ethical perspective?
I was actually just looking back at the Code of Conduct and looking at what those words actually say. it does say wherever possible, avoid providing medical care to anyone with whom you have a close personal relationship, providing care to close friends, those you work with. So it seems that that particular circumstance of providing an injection would be providing medical care, and it's with someone you work with, it's definitely avoidable. The tribunal won't care if you've caused harm or not. As I said, we won't see what happens with these complaints as they come through until they've happened on other practitioners, and we've got a bit of precedence here. So I guess each surgeon needs to determine where they are going to draw the line in terms of their practice, and whether they take the risk to continue injecting or doing procedures on people that are close to them, knowing that the risk is suspension, cancellation of their registration. And the idea of doing a quick favour for someone that you work with because you like them might not seem to be such a good idea if it goes pear-shaped and your registration is something that's on the line.
Absolutely. One of the questions that I wanted to ask you, Dan, probably, which has arisen from some of the comments that we've had in the chat around, well, can't the board trust me to make the decision myself? Aren't I professional enough to be able to draw that line? I can be objective. One of the main issues for this is lack of objectivity. Can you really be objective when treating close family and friends? Truly?
It's an interesting question, because you feel that you can when it's simple, straightforward stuff that you could do with your eyes shut. That's the reality. When we get on to, do I do a facelift on my spouse? My answer is no. There's no way I could feel objective about that. But if you're asking me, do I think I could objectively, cut a BCC off the back of my brother? I would say, yeah, I can be objective about that. But the problem is that there's more than just objectivity at stake. There are other issues that we don't have complete control over.
Yeah, and it's interesting that people have said, and we can appreciate the comments that people are making in the chat, which is, this is impractical, this is absolute, you're talking about being deregistered for, injecting a staff member with toxin, what are you guys talking about? That's not what you said, but that's the implication. And I guess the thing is that it's a matter of where you draw the line, and it's a risk. This is a risk analysis. The board has said what they expect the standard of care to be. That's the expected standard of practitioners in this country, the standard of professionalism that the board expects. And I guess it's a matter of, you determining where that line is drawn. I don't know whether Dan or Jody or Ruan, you want to make any comments about that?
I think it's really,
sorry, you go, Jody.
I was going to say, yeah, it might seem a bit harsh. You possibly wouldn't get deregistered for injecting staff members, but they could put some conditions on your registration. The other thing to remember is, and Roanne and Georgie would be able to comment, I've known surgeons that have had reports to AHPRA. The investigation process is long and they don't know what the conclusion will be. There's a lot of stress involved with that, a lot of time, and you would like to try and prevent a report being made against you to AHPRA. It's something that goes on your record. It's something that they could look to if there's another staff member that complains about you injecting. So I guess there's a lot of other little bits and pieces that add up there, which means it would be a bad idea. The benefit from injecting your staff, is it that great that you're willing to risk those other potential consequences?
Ruan, did you want to have a bit of a word about what happens when you're involved in an AHPRA or an HCCC notification or notification with the Office of the Health Ombudsman in Queensland?
Yeah, look, I mean, as Jody mentioned, it is stressful and it can be a long and drawn out process. And I think that's one of the issues here where we're looking at, again, what are the alternatives? Have you turned your mind to the issues and address them. We do see a lot of complaints and issues raised to the board by competitors or by other practitioners or by someone who may not know the full situation or someone who is disgruntled. And it's really ultimately something that can be avoided. I understand there may be some feeling that there's not nuance in this, and that's what we're really trying to encourage you to look at it from. There is words in the code, and then for the benefit of tonight, there's also the RACS guidelines and the ASPS position statement. And what that does ask you to do is actually think about the individual situation. What the cases that we have seen up until now have come through is, as we talked about before, that it's not about whether or not the treatment was appropriate or not. So the treatment might be well and truly appropriate, but because of that other relationship, the board considers that it is a breach of your professional obligations. And it is looking at, is that necessary? The issue, there are other professional obligations, as I briefly mentioned before, such as the advertising guidelines. So for example, by offering your staff free treatment, if that's something that you were doing, are you actually encouraging unnecessary treatment? Have you actually explained the risks properly to them? Do they understand? And it is in reviewing the code and before this revised version come out, I can assure you that Avant participated in the process of preparing submissions and raising the issues for our members in terms of those absolutes and not recognising maybe some of those issues and some of those nuances. And it's because of submissions from a number of people, including Avant's, that the code was revised, and we can certainly put that position forward and have done so.
Yeah, absolutely. Dan, do you have any thoughts?
Well, I think that this is a quantum change when the words go from best to avoid to must not. And I know that's not the wording that's affecting toxin, but it's the wording that's affecting surgery. And that's the wording that's going to change my practice. When it comes to toxin, I think one of the questions was, what do we do? We work with hundreds of staff, and I think that you can differentiate between staff who work for you and staff who work very, very closely with you, whom you're close to, from the entire hospital staff that might comprise thousands of people. I think that it comes down to potentially looking at the arrangements that we can have between practices to care for each other's staff in a very positive way. And that's something that I've done for many years with bigger procedures, have been to provide other practices with either discounted or no charge surgery for their staff, and people have been kind enough to do it for me as well. So I think that that's certainly a way forward. And that's possibly a way forward with injectables. But I think that the situation is not simple, and you have to work out what's close and what's close in your particular situation and what degree of control there is in that relationship to determine if this is a close relationship or not.
Yeah, I think that's right, and certainly I think it's fair to say that if we, at Avant have to represent you in a case, we will put your best case forward. So don't have any concerns about that. So we will argue whatever nuances we can argue, and I think it isn't black and white, as you say, Dan. It is very nuanced in how you deal with this. What are some other questions that we've got here? There's another question, actually one of the questions that we got beforehand, which I think is a great one. How does it differ from having a relative fix your plumbing or electricity? Who would like to take that one on? No one.
I think Georgie, that goes back to that point before about professionalism, and one of the points that Jodie made about, I suppose, the potential risks or implications. As a registered medical practitioner, there does come additional responsibilities that are distinguishable from a tradesperson's responsibilities. And I think it's important to recognise that you can still take your medical knowledge and your expertise to that relationship, in the sense of being able to identify, you know, a few colleagues who you would trust to send them to, by answering some questions and demystifying some of what they might be dealing with. But it's about recognizing that you can't objectively treat that person if that's the situation, and so you send them to someone else, or you encourage them to see someone else. So also to protect yourself from putting yourself in a situation where your objectivity is affected, or you're uncomfortable, or not treating them the same way that you would any other patient.
There was a good thought that was in the article that I mentioned before, the literature article I mentioned before, where they surveyed a bunch of surgeons, which was the question to ask yourself: do I want to still, what would happen if something went wrong in this relationship? Or, you know, do I want to maintain this personal relationship, or what would I do with it if it went wrong? And if the answer is that you want to maintain that personal relationship, then you shouldn't treat them. And I think that goes to that gut feeling that we were talking about at the beginning. If you think it's not quite right, then you should think again about whether or not you should proceed. So we've got about 8 minutes to go. If there are any other questions, please feel free to put them into the chat. I think we've probably spoken a lot about the boundaries, about the slippery slope, and where you draw the line. Are there any other comments that we haven't covered, any other issues we haven't covered, Jody, Dan, or Ruan, that you want to highlight at this stage?
Yeah, I think it's important that we don't think of this as a reason not to discuss medical issues with our close friends and family and so forth. We're an important resource for them, and we can provide them with information that they may not easily get elsewhere in a very objective fashion, as an information source rather than as a treating physician. And so I don't think we should lose that ability. And I have in the past quite often, when somebody's wanted a major procedure with me and I wouldn't feel comfortable operating on them, said, well, come and we'll talk about it and I'll tell you about the procedure. So they go to their consultation better informed. And I think we do have a particular role with our family and friends in providing them with information and keeping them safe and sending them in the right direction, but or at least guiding them in the right direction. But treating them becomes a different matter.
And I think that's a really good point, that certainly we're not saying that you shouldn't help your family negotiate the healthcare system or provide them with assistance and advice. I think the thing is not to become their treating doctor, as I think you said early on, Dan. I'm just wondering, do you have a spiel if one of your family members or close friends comes and talks to you and asks you to be their treating doctor or to perform a procedure? What would you say? Do you have some words that you would use?
Yeah, oftentimes I'll start with the idea that I'd like to talk to them about it, and I'd like to tell them about the procedure, but I wouldn't feel comfortable actually operating on them in case something went wrong. And I'll go through then making a time to sit and talk with them about what it is they're interested in having done, and give them some information about it that might send them into the consultation with whoever I recommend with a better understanding. And it may actually mean that they don't even go for the consultation, or it might mean that they're even keener to go for the consultation, but they go in informed.
And that's a really good point. And Jody, do you have any thoughts on what sort of words doctors could use?
I think similarly to Dan, I think firstly, thanking them for that they trust you enough to provide care to them. Explain the situation, that the code of conduct suggests that they shouldn't treat family or close members, and that it could jeopardise or put conditions on your registration, and that you would be happy to recommend someone that you would go to that would help them, so they've got somewhere to move to from that conversation. I'd also make sure that I'd set the expectations with staff very clearly when they're working at your practice, so they don't ask you in the first place. So other than writing in a manual, explain the situation up front before there is a circumstance that they want to ask you for that quick script or whatever. It's very clear that that's not what the relationship is about. It's an employer-employee relationship. You don't provide them medical care. And for each practitioner, just to work out where your line is in the sand. It's very grey. The code of conduct is a guide. And obviously a tribunal will make a decision should you have a report based on that guide. But if you have a line in the sand that you don't cross and you have that in your mind before a circumstance arises, you can then address that circumstance and keep on the side of the line that you'd like to.
Yeah, absolutely. And I think it's really important, that issue around boundaries and staff. If you do have to treat staff and it is unavoidable, the advice that we give is to make that boundary very clear. So don't see them in the corridor, see them in your rooms, and make it very clear that you're having that consultation. And that's certainly the advice that we give to practitioners who are in rural areas and in small communities where you do know everybody. And it would equally apply if, you know, to your circumstances if treatment is unavoidable. Ruanne, do you have any further comments on that?
Yeah, absolutely. You're right, Georgie. And recognising, I mean, as lawyers, we often stress the importance of documentation, but where you do find yourself in that situation, just making sure that it's clear in your notes that you've turned your mind to the issue, and you do have a formal arrangement so that the doctor-patient relationship starts when they enter your consulting room. It's not something that you're doing in a social setting. And that you document that clearly, that you disclose it where appropriate to any other treating clinicians. And you also recognise that if you think it's okay at the start and then it becomes difficult, then you do look at other options and you then refer off if it does become something that you thought was okay, but you start to either feel uncomfortable or feel that your objectivity is being clouded, that you recognise those situations early on.
Yeah, so it is all about recognition, as the board says, recognition and good management of the issues, drawing a line in the sand where you won't cross, and determining how you manage those situations, within the bounds of the boundaries that you're putting around you. Jodie, you wanted to say something?
I was going to say, and if you do decide to perform surgery or treat someone that might not be really close, but someone that maybe a theatre staff member or whatnot, ensuring that documentation, as Roanne said, but that's really important if something does happen, that you can do a proper handover to someone else and you've got all the notes very clear, so that's not a drama if you need to go down that track.
Absolutely. So I think we've almost at the end. I've switched over to the last slide because we're kind of covering off the key messages, but I do want to just ask whether there's anything else that our panel members want to say. Dan, anything else that you want to highlight?
Well, just remember that these changes affect all areas of medicine. This is not targeted at plastic surgery. And remember that professional boundaries are not just sexual boundaries. They're way more complicated than that. And we're not talking about absolutes. And, we do have to have a real understanding of our responsibilities in a really subtle manner.
Great. Jodie?
As you said, it affects all of medicine. Maybe if you're unsure, you've got a particular circumstance, talk it through with a colleague, get their thoughts, because they might be able to give you a different perspective that makes you think about things differently. Absolutely. Ruanne?
Yeah, and I think it's important to think about the guidelines as just that, as something that you can rely on to guide and inform your professional approach and opinion, and not see it maybe as something being imposed on you, but that's something that's also there. We speak to a lot of members. My day job is answering the phones when I speak to members, and a lot of them actually want something to rely on to be able to draw that line. So you can actually use it to your advantage and say, actually, the board says that I should, recognise the personal relationship and not treat you, but I can certainly, the best way that I can help you in this situation is send you to someone that I would trust.
Yeah, I think that's a great place to end. And apologies that we didn't get to that very last question, which would have the person who wrote it will know who they are, and we would have done almost a whole webinar session on that issue about whether nurses can do Botox injections on you. So we'll leave that for another time. Thank you everybody for joining us. I appreciate that this is a controversial topic and that many of you are not happy with the messages we are giving you today, but we do want to leave them with you so that you can reflect on them and think about your own situation and draw that line in the sand. So all we need to do now is to say good evening. Would you please, we'd appreciate it if you could do our survey at the end. So just click on the button when you leave that says do survey or continue or something like that. It's a blue button. So if you could do that. Thank you very much to everyone for joining us. Thanks panel members, and I'll get you all to say good night as we sign off. So good night.
Good night.
Thank you.
Good night.